Hello, my name is Megan Murphy-Grayson. This is the presentation portion of my evidence-based project, Part 5. I'll be examining any potential relationships that may exist between alcohol use disorder, post-bariatric surgical patients, and nursing-led educational programs. First, I'd like to begin by discussing the prevalence of morbid obesity in the United States. Since the 1960s and 70s, rates of obesity in the United States have nearly doubled. This is of grave concern because obesity increases many risk factors for developing chronic health issues like diabetes, sleep apnea, and hypertension. These can be challenging to clinically manage and often become more severe over time. First-line treatment for obesity is diet modification and increased exercise. When several unsuccessful attempts have been made to lose weight with these behavior modification tools, the patient is often referred to a bariatric surgery to undergo weight loss surgical options. To qualify for bariatric surgery, the patient must have a BMI of at least 35 and often requires a combination of comorbid conditions that are complicated by their extra weight. For example, diabetes, sleep apnea. Although the surgeon and the healthcare team will discuss any possible surgical complications or possible side effects and necessary lifestyle changes that the patient must make in order to be successful with weight loss surgery, there is recent research to suggest that bariatric surgery can increase the risk of developing alcohol use disorder. This topic became an interest to me because I had bariatric surgery when I was 19 years old and found myself developing an unhealthy relationship with alcohol over a 10-year post-operative period. And similarly, I had heard problems echoed from peers who had also undergone bariatric surgery. So anecdotally, over time, more and more people that I had met that had had bariatric surgery started to share very similar stories of alcohol abuse with me. An important aside to mention is that I very proudly have not had any alcohol to drink in nearly 3 years now. My initial hypothesis before starting this research was that bariatric patients have undiagnosed food addiction, which undergoes a transfer of addiction post-surgically, where they replace their old addiction with a new substance to abuse. In terms of bariatric patients, and this study, it would be food for alcohol. However, my PICO question focused more on what nursing-led educational programs could do in reducing this risk by educating pre-surgical bariatric patients about this potential risk. I was unable to answer my PICO question because no such nurse-led educational program exists to standardize this education for pre-surgical patients. However, it is my hypothesis that if a program like this did exist, it would do very well in helping reduce the risk for these patients. One research study that I looked at had a very successful nurse-led educational program for pre-op bariatric surgical patients to teach them about what to expect after surgery in terms of diet, physical recovery, and things to look for after surgery in terms of self-care and remaining healthy. The result of this nursing-led educational program was very successful in that patients reported a higher sense of their ability to care for themselves and understanding of what to expect after the surgery, and also reported greater rates of satisfaction with their healthcare experience. It is my belief that if a nurse-led educational program within bariatric surgical practices throughout the United States began to implement a similar program and additionally added the curriculum to discuss the risk of alcohol use disorder, it would greatly reduce the risk of this becoming a real possibility for patients, and it would give them an ability to navigate around this potential serious complication. The research did show that there is an increased risk in developing alcohol use disorder after bariatric surgery. Very specifically, those patients who underwent a Roux-en-Y gastric bypass procedure were more likely at risk to develop alcohol use disorder. The current hypothesis is that this particular procedure, and the way that the duodenum is bypassed and the stomach pouch lacks a muscular sphincter into the small intestines, somehow changes the way that alcohol is metabolized and absorbed into the body, which leads to an increased rate of intoxication. It is my hypothesis and belief that nurses are perfectly positioned as the primary provider of patient education to lead a nurse-driven educational program that becomes a standardized tool across the country for all pre-surgical bariatric patients to attend educational classes that discuss complications, risks, and lifestyle modifications that are going to be required post-bariatric surgery. There should be an important emphasis on the risk of alcohol use disorder, particularly in patients undergoing a Roux-en-Y gastric bypass procedure, because of the aforementioned associations and risks the research mentions on the previous slide. I would like to conclude this presentation by saying thank you so much to Professor Cross for your support and continued flexibility throughout the summer semester while I finished completing the previous semester's work. It's been very comforting to have your support, and I appreciate your wisdom, knowledge, and guidance throughout this process. Thank you so much, and have a wonderful summer.